Thank you, everyone. We will now proceed to start our next session on WHO goal of HBV elimination by 2030. How far is too far? For that, we would like to invite our moderators on stage, Dr. Atul Sajdev, Dr. Parveen Malhotra, Dr. Naresh Kumar Khanna, Dr. Rachit Agarwal, Dr. Ravi Daswani, and chairpersons Dr. Anil Kumar, Dr. Ram Gupta, Dr. Abha Nagral, Dr. Rakesh Kumar, Dr. Girish Kumar Pathak. For the first talk on how close are we in achieving a functional cure of HBV, we would like to invite our speaker, Dr. Vivekanand Saraswat.
Good afternoon. I'd like to thank Dr. Anil, Dr. Ashish, and Dr. Praveen for this kind invitation. And in the next 12 minutes or so, I'll try and take you over where we are in 2025 with regards to functional cure of hepatitis B virus infection. This is the B virus, its core, and its life cycle. Now, the first we need to know, what do we mean by cure in the context of hepatitis B virus infection? Almost for every microbial infection, cure means final terminal elimination of the pathogen from the body. However, for hepatitis B, we talk of functional cure, which is, according to the 2022 EASL ASLD definition, after completing a finite course of therapy, there should be sustained surface antigen loss for a duration of 24 weeks or longer, which may be with or without seroconversion to anti-HBs, and with undetectable E antigen and serum HBV DNA. Now, why are we not able to? This is an achievable and endpoint, which is now the current target of all studies and trials. Why we are not able to achieve sterilizing cure is because that needs, apart from functional cure, elimination of CCC DNA and integrated DNA sequences, which currently is not feasible with available therapies. Partial cure is a suboptimal surrogate for functional cure and refers to a finite course of treatment followed by reduction in surface antigen level to below 100 IU per ml, but still the surface antigen is detectable. Patient is E antigen and negative and with undetectable DNA for at least 24 weeks after completion of therapy. That is the definition of partial cure. Now, what are the challenges? Why are we not able to achieve sterilizing cure in the hepatitis B virus infection? An important reason is the massive rates of production of the virion and subviral particles, that is 12 log virions per day and 15 log subviral particles, spherical and filamentous forms that you're seeing here on the electron micrograph of the virus, which results in exhaustion of immune function, that is T cell as well as adaptive as well as innate immune responses. If we are able to suppress this massive overproduction, there are clear-cut demonstrations that we can restore the exhausted immune response. Another reason is the CCC DNA. Up to 50 copies of CCC DNA can be present on every infected hepatocyte. And since this is the transcriptional template for all RNAs and pre-genomic RNAs of the virus, this contributes to the massive overproduction of the virions and subviral particles. To date, pegylated interferon is about the only molecule which has been shown to increase degradation of CCC DNA. Finally, we have the problem of integrated DNA segments, sequences, and every infected hepatocyte has at least 2 to 4 of these segments. Generally are incomplete, but usually contain the surface antigen and thus contribute to the high load of surface antigens we see. Finally, and probably the biggest practical challenge is that when we come up with a cure regimen, it has to be superior and better than the existing standard of care, which is second generation nucleoside analogs, which can be given orally, are very safe, do not produce resistance, and are cheap and widely available, all very tough benchmarks to meet. Now, what can be the various components of a strategy for hepatitis B virus cure? Inhibition of viral replication, generally achieved with nucleoside analogs, is the main, but newer directly acting antivirals are also effective in suppressing viral replication. The inhibition of this massive overproduction of surface antigen as well as its secretion with newer DAs, directly acting antivirals for hepatitis B, and finally immunomodulatory therapies which will restore the HBV specific immune response, TLR, TLR7, 8 ligands, checkpoint inhibitors, therapeutic vaccine. And interestingly, pegylated interferon figures in all three boxes, so it's an integral part of this functional cure strategy. Now, where are we with the currently available strategies for functional cure? Currently available therapies for hepatitis B are basically monotherapy with pegylated interferon, using second generation nucleoside analogs, entecavir, TDF, TAF, or using them in combination with each other. What are the results with monotherapy? Pegylated interferon alpha after 48 weeks, the end of therapy surface antigen loss is small, 2 to 3%. But over the next 3 to 5 years, it can go up to as much as 8 to 14%, which amounts to a functional cure in many of these patients. However, this is only seen, predominantly seen in genotype A, which is uncommon in our part of the world. Nucleoside analogs are very poor at clearing surface antigen, and even after 10 years, barely 2 to 5% will achieve S antigen clearance. Recently, there has been interest in withdrawal of long-term nucleoside analog therapy, which can increase the surface antigen clearance seroconversion rates in people who have been virally suppressed with long-term nucleoside analogs, E antigen negative chronic hepatitis B. After 2 to 3 years of sustained viral suppression, when you withdraw treatment, there are now studies to show, particularly in Caucasians, that this can result in increased rates of surface clearance and surface and seroconversion. Generally, this happens if the viral load the surface antigen load is down to below 1000 MIU per ml amongst Europeans and less than 100 MIU per ml in Asians. However, this is a strategy which is unlikely to contribute significantly to functional cure globally, because most of the Asian and African populations will not benefit with this strategy. The combination therapies that have been tried include simultaneous use of nukes and PEG interferon, add-on therapy or sequential therapy of various combination of nukes and PEG as shown, or it can be switch therapy from nuke to PEG or PEG to nuke. However, the results with this are still not very encouraging. De novo therapies have not really shown any improvement in surface antigen loss, whereas add-on therapies or switch therapies in selected patients have shown reduction in surface antigen, but functional cure has not been reported with these combinations, and currently they are not approved by any guidelines. So, what are the newer directly acting antivirals for Hep B and immunomodulatory drugs in this condition? These are directly acting antivirals include DNA polymerase inhibitors, the well-known nucleoside analogs that we are using all the time. Entry inhibitors like bulevirtide, which blocks the NTCP receptors, capsid assembly modulators, translation inhibitors. The mRNA of the hepatitis B virus is inhibited by these translation inhibitors, that is small interfering RNA or antisense oligonucleotides. And finally, molecules that block hepatitis B secretion from the cell, the nucleic acid polymers. Immunomodulatory agents, the first and foremost is pegylated interferon, but TLR7, TLR8 agonists, checkpoint inhibitors, which we are more familiar with in the context of HCC, therapeutic vaccines as shown here, as well as some studies now with monoclonal anti-HBs to remove the excess surface antigen in circulation are some of the newer studies. How do they act? Anti-HBs will bind and block the virion. Viral entry will be blocked by NTCP receptor inhibitors. The uncoated virus, once it enters the cell, forms cccDNA, which is transcribed into various messenger RNAs and pgRNA, and this step is blocked by sRNA and ASOs. The viral mRNA products are then assembled to form the nucleocapsid, which the CAMS will block. The major molecule we use is the reverse transcriptase inhibitors, which prevents the RNA from forming negative strand DNA and positive strand DNA. And the assembly of this into intact virions and subviral particles and their secretion is blocked by the NAPs. Immunomodulatory agents will act on the innate immune response and have numerous downstream effects. The immune channel inhibitors like PD-1, PD-L1 inhibitors will restore immune exhaustion and have an effect on innate as well as adaptive immunity and natural killer cells. Therapeutic vaccines will also have effects on the various arms of the adaptive immune response. Vaccine antibody, apart from binding the virions in circulation, form immune complexes which provide better antigen presentation to the effector T cells. And finally, PEG interferon through inhibiting natural by stimulating natural killer cells, and also through the JAK-STAT pathway, the interferon stimulating genes are stimulated, which leads to CCC DNA degradation. So we can understand the molecules by which they will help. These various molecules have now entered clinical trials, CAMs, siRNAs, ASO, NAPs, and amongst immunomodulatory agent TLR 7 and 8 agonists, therapeutic vaccines, and monoclonal antibodies. What are the results with these therapies? Now, this slide shows phase 2 results with the use of single agent amongst the DAs or single agent immunomodulator, and the results are quite disappointing. They are not really effective in lowering the surface antigen at end of treatment or at 24 weeks by more than 1 log, and they do not achieve functional cure. However, when we use two of these DNAs together, or DNA and immunomodulatory agent together, the surface antigen clearance in some combinations can cross 20% up to 30% and at end of treatment, and can reach almost 20% at 24 weeks, as the same as is shown here. So at least these molecules offer advantages that the benchmark of more than 20% end of response treatment and 24 weeks zero clearance can be achieved with some of these combinations. The promising combinations here are nucleoside analogs with PEG with NAPs, the nucleoside polymerase, 60% end of treatment clearance and up to 35 at 24 weeks, the most encouraging results we have seen with immunomodulatory treatment. However, small numbers, no follow-up data, and flares were seen during this therapy, so more results are needed in this area. The bepirovirsen, which is an antisense oligonucleotide, 300 milligrams for 24 weeks with nukes and pegylated interferons, also gives about 65% end of treatment and used in various combinations and lower doses up to 24 to 40% 24-week clearance at the end of 24 weeks, which are very good results. But when it is used only with nucleic acid analogs, the ASO gives much underwhelming. Only about 10% at 24 weeks will achieve sustained, that is, functional cure. A combination of pegylated interferon, siRNA, and nucleic acid inhibitors up to 23%, while a 4-drug combination trying to combine siRNA, nucleoside analog, CAM, and PEG will only give 16% versus 14% for PEG alone. So that probably is not that promising. And the strategies that have been suggested, so now we should combine molecules that decrease replication, decrease new infections with those that decrease viral antigenemia, and stimulate the innate immune and adaptive responses. Many challenges still need to be addressed, some of which I don't have the time to go through but are shown on this slide. And so it is likely that future regimes to achieve a functional cure in HBV infection will use a combination of current and newer therapies like nucleoside analogs, HBV translation inhibitors, siRNA and or ASOs, capsid or secretion inhibitors, CAMs and NAPs,